Maybe that one.
Sorry? Oh, okay. Okay. Okay, okay. Then we may have to change the following dates already.
Just a few more minutes.
Mami nunggu is the one.
Actually, they are on timelines. Yeah.
I just come back now to even talk to you then.
That's why.
Okay.
Okay, hello. Hi, nurses from Francis Villa. Hello.
Hi.
And nurses from St. Joseph Nursing Home, hello. And nurses from Sri Narayana.
Hi.
Hello, good afternoon. This is the mic. Oh, this is the mic. Okay. So, just to introduce myself, my name is Amy and I'm the dietitian from Khoo Teck Hospital. So today we are going to share a little bit on the prevention and treatment of malnutrition in elderly who are staying in a nursing home. Okay, so what basically is malnutrition in the elderly? Okay, you can take a look at this picture. It doesn't have to be always a deficiency, but it could be an excess of nutrition or imbalance of energy, protein, and other nutrients, such as like if the patient has a lot of loss, like after surgery or any acute illnesses, that will cause adverse effects on body function and also clinical outcomes. So, a lot of times, actually, we know that undernutrition is more of a problem with the elderly, where it would increase the mortality rather than the problem with overnutrition. So, why are elderly people, they are more prone to undernutrition? Firstly, do you all see this slide? So basically, we have sensory impairment. We know that actually elderly, they would have a change of their sense of taste as well as smell and hearing. That would also affect their appetite and the amount that they eat. Of course, denture would be a problem as well. If they have any swallowing issues or denture problems, it will also affect the quality of the diet that they're taking. And as well, they would probably need lesser energy intake, but at the same time, actually, their nutrient needs, like for example, vitamin A, vitamin D, calcium, all these would still be the same or even higher than a younger person, but yet their energy intake is reduced due to reduce of metabolic rate and also decreased physical function. So it becomes harder to get enough nutrients just from food itself. And of course, there's another common issue that is with elderly, is sarcopenia, which is actually a muscle loss during when they are getting older. So this one would actually also affect their functional ability, so that they would be more prone to falls, and other issues would be from psychological isolation. Like if they're eating alone, they probably would have lesser appetite, and also financial issues would also be a problem to getting good quality kind of diet. So all these would actually accumulate, and also it will actually lead to progression of undernutrition, where the patient is actually not getting enough. And just now, as I mentioned, right, undernutrition would lead to increased morbidity and mortality. And so therefore, early detection of malnutrition is very important, so that we can prevent all these issues from happening. Okay, so just as I mentioned, when we talk of malnutrition, we are not just talking about undernutrition. It could be excess overnutrition as well, where they're eating a lot of high fats or high sugar food. But undernutrition seems to be more of a problem with elderly patients because it affects the mortality as well. So with undernutrition, we understand that just now there's a lot of different factors. So we also see the 3 circles here as well, where we see starvation, which is a pure calorie deficiency, and it's reversible by feeding the patient properly. There will be cachexia when patient has inflammatory issues, where they are probably having, say, long-term kidney diseases or cancer, and sarcopenia, which is just a age-related muscle loss due to physical inability. And loss of muscle tissue as they age. So we see the complexity of all these things in malnutrition or in undernutrition. So we also want to note, the prevalence of malnutrition in residential homes in Singapore. And we have these 2 references where actually the studies show that around 22 to 85% of the residents in nursing home will have a risk of malnutrition. And also with this other study where we found out that by Chen et al., also done in Singapore, we found out that there's 53% of the residents as undernourished with a BMI less than 18.5, and 39% as malnourished with mini nutrition assessment score of less than 17. So actually, we can see that actually the prevalence of malnutrition is rather high in residential homes for the elderly. Okay, this one is just a piece of news that I come across from when I'm searching for information on this topic. Then this person, I think he's quite well-known geriatrician in Singapore as well, Dr. Chan Kin Ming. He was being interviewed and he actually quoted this study which is done by Abbott. It's a survey, found that nearly 30% of elderly have moderate to high malnutrition risk. And then he mentioned that we are looking at a number of 300,000 of these older people who are at risk, so it's a huge number of people. And according to this survey, they actually found that only 1% of the elderly are meeting the dietary guidelines, the healthy diet pyramid that is advocated by the government. So we know that actually there is this problem of malnutrition in the elderly. And here we have another National Nutrition Survey 2010 in Singapore, where we know that people who are at the age of 60 to 69 years are consuming less brown rice, red rice, and also they usually tend to take lesser fluid, which is less than 1.5 liter per day, and they also consume less of the milk and milk-based beverages in Singapore. Okay, so we may want to ask whether malnutrition have negative effect on outcomes. Okay, we take a look at this picture. We know that people who are malnourished, especially older people who are malnourished, are at risk of increased falls, and if they are admitted to the hospital, they will usually stay longer, and longer stay in rehabilitation or institutionalization, and also higher post-operative complications and infections, pressure ulcers, poor wound healing, impaired muscle and respiratory function, and even death. So we understand that actually with undernutrition, it will lead to poor outcomes. So what should we do? Okay, so I believe most of the nursing home would have a strategy to monitor or screen out patients who are actually at risk of malnutrition. Okay, so can I ask all of you one question and see whether you can answer? Would you think that one of the following parameters would be adequate for screening? Like just taking weight or BMI, or just doing some tricep skin fold, or calf circumference, if some of the places would be using those, or labs like albumin or hemoglobin, or this kind of lab parameters. Do you think one of these would be enough to help us to screen out patients? Anyone?
I think yes.
Are you using BMI or are you using weight? What are you all using there?
Wait.
Weight. How often do you weigh a patient?
Monthly.
Two monthly. And St. Joseph?
No, monthly. Once a month for normal patients. Then
Okay.
rise to cases every 2 weeks.
Okay. Every 2 weeks for at-risk patient, is it?
Is a rise to cases.
Oh, rouse
Patients
to.
with rise to feeding, yeah.
Okay, so you do weigh them lah.
Yes.
Okay. Then Sri Narayana. Did I pronounce
This is Sri
correctly?
Narayana Street.
Right, that one's in
The one who answered was Sri Narayana.
Huh?
The one who answered was Sri Narayana. So St. Joseph.
Just now the answer from Sri Narayana.
That one is St.
Narayana.
Joseph. Oh, this one is St. Joseph.
The right is Sri Narayana.
Okay, sorry.
So same just.
Joseph has an answer.
Okay, St. Joseph haven't answered. Answered already, right? Haven't St. Joseph? I thought they monthly, right? Okay. Is it adequate? Do you all think it's adequate? Just doing weight? Not enough. Very good. Okay, so let's take a look at. Okay, let's take a look at BMI. Okay, so we know that like local studies on older persons, we know that a low BMI of less than 18.5, it's a highly significant predictor of mortality. And in overseas, there's another study where they found out that BMI of less than 23 or any reduced oral intake actually will associate with higher mortality in quite a large prospective study by Flecker. And others, true retrospective study found that low BMI was associated with increased 1-year mortality in community living geriatric patients. Okay, so actually we know that just as I mentioned earlier on, we know that undernutrition, which is often reflected by a low BMI, will actually increase mortality. And the cutoff point is, according to these data, will be around 18.5, and some would be even higher than at 23 lah. So, but the issue with BMI is what could be wrong with just taking the weight? Yeah, height would be a problem because I guess it's quite difficult to estimate height in a nursing home, especially with some vertebral compression and also with the mobility and all that. But sometimes we do use this knee height caliper, right? This is the one behind me. Anybody using this in the nursing home?
No.
We don't have.
How do you estimate the height? This one is the knee height caliper.
Measuring tape. We are using measuring tape.
Measuring tape to measure what?
The height.
Arm span? Half arm span? Or the whole body lah? You just stretch out.
The whole body, yeah.
Okay, so it may not be a very accurate, right?
Yes.
Because no study of validity of just using a measuring tape from the toe to the head, right? So it may not be very accurate. Plus, they may have contractures, and then they may be vertebral compression as well. So you can't really do a proper measurement.
You can't do exactly, but because the nursing home patients, most of them is not able to stand or all those things.
Yes, correct. So I think this knee height will actually help because they just measure the height from the knee to the heel, and it can there's an equation to help you to estimate the height. There is an Asian one and there's a Singapore one. If you're interested, let me know. I can send you the formula as well. Because previously one of the dietitians has done a project on this, and then they have come up with their local equation. So again, height is not accurate, so your BMI may not be very accurate reflection of the true status of the nutrition or malnutrition in the patients. Number two, there may be some edema and ascites in the patient where it could happen because I remember previously I had a patient. I call up the nursing home. The nurses in the nursing home are all very good. They are very diligent in taking body weights every month. So I usually, when they're admitted, I'll call them and ask for the 6 monthly weight changes. So this gentleman hasn't been eating well for 2 months. By right, his weight's supposed to decrease, right? But actually, on admission, his weight is higher than when he was in a nursing home. So I just called them up, and the nurse explained to me that, oh, actually, the patient hasn't been eating well, but yet the weight has gone up. It's because when they measure the weight that time, they actually notice there is bilateral pedal edema, where there's a few kg of weight gain. So just tracing the weight would not totally reliable in screening out patients who actually have nutritional problems. So just now, whoever has answered that question whether BMI is adequate is actually no. I think that is very good. Okay, then this is another study which was shared at this Regional Asia Pacific Osteoporosis meeting, where these researchers from NUS and MOH have done a study on these elderly patients, especially on men, basically on the risk of fractures with antioxidant. And during the study, they actually found that low BMI is a strong risk factor for hip fractures, risk in elderly men comparing to women. And the BMI is at less than 20 kg per meter square. So if your patient, especially men, if they are less than 20 BMI, then they may have a higher risk of fracture. Okay, so so much about body mass index. There's actually no reference for elderly people, like a BMI range for elderly people in Singapore. But just now we have shared a few results from a few studies. We understand that actually at a BMI of less than 18.5 in one of the local studies actually shown that there's an increase of mortality comparing to those normal and intermediate BMI. But there is no study or no consensus on a higher BMI cutoff point where, whether it's better to have a higher BMI for a reduction of risk or mortality. There is no answer to a upper limit of the BMI. So that's why we are still using the WHO classification of weight, whether it's underweight, overweight, or obese, and also the local guidelines for Asian, adopted for Asian, for cardiovascular and disease risk, which is on your right hand side. So we're still using the general one for the adults. Okay. Okay, so in the elderly, lowest mortality associated with BMI range, this one is from US of BMI 20 to 30, and relationship between BMI and mortality weakens with increasing age. And of course, if there's obese patient and got cardiovascular disease or diabetes, then probably weight reduction can help to reduce the risk of CVD. Okay, so if you are monitoring weight, it's a very good thing. I'm not saying that you don't monitor weight at all, because this can give us very useful information if you're doing it regularly, like monthly. Of course, if you do it as a one-off kind of measurement, then it wouldn't give you any valuable kind of information. So you see, within 1 month, if there is a 5% of weight loss, then it's considered as high risk of undernutrition. And if in the past 6 months the patient has lost 10% of their usual body weight, then it's considered as undernutrition. So we see that actually a 10% of loss of body weight over a 6-month period is a strong predictor of mortality in the following 6 months in a nursing home residence. So I think it's very good. I mean, this could serve as a indicator of the nutritional status of the patient, and you can actually track their weight to screen out the ones that who needs intervention with their nutrition plans. This is one of the nursing homes in Singapore, and one of actually we are servicing a few nursing homes in Singapore as well. And then this is the weight chart of one of the nursing home where they would do a weight of the patients monthly. So you can see from August 2011 to January 2012. So they would have they put it in an Excel file, and then they would track the weight changes, and it would tell them the percentage of weight change over the 6-month period. So next is anthropometry. Okay, so the usual anthropometry that we use now would be skin fold thickness. I'm not sure whether you all have this in the nursing home, but I'm just demonstration purpose. So this is the caliper that we use for skin fold thickness measurement. Okay, so it could be on your bicep, tricep, and on the scapula, which is the one that is shown on the slide. And also the common anthropometry that we actually measure would be the calf circumference, which is the other picture that you see on the screen. Okay, so they are actually non-invasive. They won't feel any pain or anything, and it's simple and it's convenient, but you need to have the skill. And also basically, okay, the skin fold thickness, the picture on your left actually reflects subcutaneous fat losses, and the other one, the changes, the calf circumference and the mid-arm circumference, which is the circumference here, would tell you the change in lean body mass and fat as well. So, but the problem with this is it varies with age and gender and ethnicity. So, and also if there is edema, it wouldn't be very accurate. So on its own, it doesn't really tell you much. Okay. Others would be biochemical markers, which basically it's serum albumin, transferrin, lymphocyte count, and all the micronutrients. Again, no biochemical marker on its own offers a satisfactory screening test because most of it are not really nutrition specific. It could be influenced by other factors as well in the clinical state or the medical condition of the patient as well. So it's useful in part of the nutrition assessment and also monitoring, but it could not be on its own as a screening tool. So would one of the following parameters be adequate for screening? The answer is no. So what do we do? Okay, so we got to have this nutrition screening which is done properly, and the tools must be validated and tested. So definition of nutrition screening is a process of identifying patients, clients, or groups which may have a nutrition diagnosis and benefit from nutrition assessment and intervention by a registered dietitian. In simple terms, you have to use a trusted tool, a very simple and easy to use tool to screen out at-risk patients. So you're not giving a diagnosis. The patients still need to be assessed by a dietitian in order to find out what is the main issue or nutritional issue of this patient. And then the dietitian would design an intervention for the patient. So basically, the dietitian's role is to advise you to choose a good tool to use, and then you are to screen out all your patients. So in acute hospitals, it's mandatory that we screen out all patients, all our inpatients within 24 hours of admission. So we need to find a purposeful one, a simple, a quick, non-invasive, and a valid tool. Okay, so there are many different tools, and the highlighted ones are the ones that are reliable, as they have been studied and validated. So you can use MST or NRS or MNA short form. So these are some of the screening tools that we can use. Okay, so if you're interested, this is the study that have looked at the different tools. Okay, so this is the NRS 2000. They only have 3 questions. And then they look at the weight loss, as well as they look at the disease state of the patient, and very quickly you can come up with a number. So the number would show whether the patient is at risk or not. And this is actually NRS has best rating according to this study. Okay, the other is MST. So this one is also very simple. You can see that there's only 2 questions that need to ask. Have you or the patient that lost weight recently without trying? So it's referring to the past 6 months. A second question is, have the patient been eating poorly because of a decreased appetite? Then you sum up the score. If the score is more than 2, then it's at risk. So it is very simple to. Then the other one, this one is the MUST. This one has 4 steps. Then, like the first one, we will have to find out the BMI. Second one, whether there's the weight loss and how many percent, then you get a score for that, and then whether patient has an acute disease. Step 4, you will get an overall score for the patient. If score more than 2, that means a high risk. And then step 5, it will tell you what your management should be. So if it's a low risk, then you would, for care homes, it will be a monthly re-screening. For hospital, it will be a weekly re-screening. Then if it's a medium risk, then you observe, and then you should have a protocol in your nursing home. Let's say those are in between ones, they may need or may not need to be referred. Then you may have a protocol to say add a nutrition supplements or give them a higher energy snacks or something like that. And then you reassess them in a month's time, at least monthly. And if the patient is improving or eating better, then you decide, or maybe patient is okay. If the patient is still considered as at risk of malnutrition, then you can then refer to dietitian. Of course, if it's a high risk, then definitely then you would put up a referral to the dietitian, and the dietitian will do a proper nutrition assessment to find out the diagnosis of the nutrition diagnosis, and then we would intervene and help the patient with their nutritional problems. Okay, so monitor and review plan is also very important. In hospital, it will be a weekly one, but in care homes, this is recommended as monthly. So you can choose a tool that you want, and then you can formulate some kind of protocol that for action for your low, medium, or high risk patients. Then the other one, this one is a mini nutrition assessment, but it's a short form where you use it to screen out your patient. Again, MNA would ask a few more questions on, apart from the appetite, weight loss, mobility, as well as problem with dementia and depression. And also there is one extra one on calf circumference as well. So they will also grade the persons with normal or at risk or malnourished according to the points. So all these different ones, you can actually choose the one that it's convenient for the staff. Of course, the staff would have to be able to perform it, and also patients also, you have to be a non-invasive and easy to use tool. So in KTPH, we do have our own screening. As I said, this would be in our nursing admission screening form, where the nurses would do the screening for us. So basically, we also ask a few questions on disease state, oral intake, unintentional weight loss, and BMI. So we would score the patient. If the patient is scoring at 7 or more, then the nurses will refer to the dietitian for nutrition assessment. Okay, so next step after your nutrition screening, then there will be a nutrition assessment, which is basically the dietitian's job. So it will be an in-depth nutrition evaluation of the patient. So we go through the medical history, nutrition, medication history, and physical examinations, and also anthropometric measurements. We have to do skin fold thickness or other measurements, and also the lab results on albumin and transferrin and other things that we talked about earlier on. So we will look at all these to come up with a nutritional issues, also the dietary data as well. So we would come up with a nutrition diagnosis so that we know what's wrong with the patient, and then we can try to intervene nutritionally. Okay, so the nutritional assessment tools that we use in the acute hospital would be SGA, but the one that has been validated for older patients in nursing home would be this mini nutrition assessment. So this is the one that we are using in the hospital. Okay, so we take down all the 5 areas that just now I mentioned that we will ask in the form, as well as we put in the weight, height, BMI, and albumin as well.